can start.
Good evening, all of you, and a very happy new year. Today's subject is very important, and the speaker is also well versed with the subject. So I hope this webinar will be very fruitful to everyone. It is my pleasure to welcome our President, Mr. Premru Palwa, our CEO, Saranga ma'am, and our speaker, Dr. Nita Radhakrishnan, who has a wide experience on this subject. I would also like to welcome Ramuji, our Vice President Development, and the management team, EC team, and our WG committee, and all of you present here for this important webinar. Thank you. Over to Satyashri.
Thank you, ma'am. Good evening, everyone. I'm Satyashri, Regional Women's Representative for South. So on behalf of HFI Women's Committee, I would like to extend a warm welcome to each one of you present here. We are thrilled to have you all connected with us virtually and excited to share for this 1 hour. Today's agenda promises to be engaging, informative, and thought-provoking. We have an exciting speaker with us with the topic Bleeding in Girls and Women, Recognition and Care. So I request you all to sit back and relax and get engaged. So we encourage you to participate, ask questions, and share your thoughts and insights at end of the session. So now I request our Indra ma'am to address the gathering and give a gist about the speaker. Ma'am, you're not audible. You're not audible. Okay, now I request our president to address the gathering.
Thank you, Satya. Am I audible?
Yeah, no, you're audible.
Okay, excellent. Okay. Thank you, Indra ma'am. And I think it's fantastic a way to start the new year. Wish you all a very, very, very happy new year. We have a fantastic doctor with us. And I'm actually traveling. I'm not in Bangalore. I'm in Delhi. And will be in the thing. But the most exciting thing is this year's entire thing, even of the World Federation, is women and girls with bleeding disorder. I think this is a very apt way of starting our Hemophilia Federation India's first program in this calendar year is done by the women's group. It's fantastic. And kudos to the entire team for organizing this. And a special, huge thanks to Nita ma'am for agreeing and joining too. So, wishing the very best. And thank you so much for having me also.
Thank you, Prem sir. Now I request our VP Development, Mr. Ramoji, to speak a few words. Natraj, is Ramu sir on the thing?
Conservation projects? No, he's not here.
Okay. So now I request our CEO, Saranga Panwar ji, to speak a few words.
Has she joined?
Yeah, ma'am. She has joined. Okay, or shall I start with the introduction, ma'am? You're not audible.
Yeah, I'll give the introduction.
Yeah.
Okay. Dr. Nita Radhakrishnan, additional, read it again. I lost somewhere. Dr. Nita is an accomplished additional professor and head of the Department of Pediatric Hematology Oncology at the Postgraduate Institute of Child Health, Noida. With extensive expertise in pediatric hematology, oncology, she has made significant contributions to the care and treatment of childhood cancers. Dr. Nita holds key professional roles, including serving as the chair of the Childhood Cancer Working Group of the International Pediatric Association and as a member of the International Society of Pediatric Oncology SIOP, where she is actively involved as a board nodal officer for Asia. Her commitment to advancing pediatric healthcare extends to her involvement in various national initiatives, such as being a member of the expert committee for the Sickle Cell Elimination Mission 2023 and a dedicated advocate for hemophilia and thalassemia services in GB Nagar. She is also an executive council member of the Indian Society of Primary Immunodeficiencies. Dr. Nita has authored 77 peer-reviewed papers contributing to the scientific community's understanding of her research interests, which include hemoglobinopathies, primary immune deficiencies, hemophilia, and childhood cancer care. Her multifaceted expertise, both in clinical practice and research, positions her as a leader in improving pediatric healthcare outcomes on national and international fronts. Thank you.
Thank you very much, ma'am. Before we start, I would like to thank the organizers for this kind invitation. And I can see a lot of, I can see Prem. I can see a lot of women's group members here in this audience today. Very happy to meet all of you, Anupama and Devi. And so when we used to have women's group activities more commonly, I think we used to interact more frequently. And I would like to also thank Indra ma'am for this invitation and taking me through this process of deciding what to speak on and how to go about it. So next, I think couple of a little more than half an hour, we'll discuss women bleeders. So why is it important to recognize this bleeding in girls and women? And why is it often under-recognized? And when we see this bleeding, how are we supposed to manage? That is what we'll discuss in the next half an hour or so. So this is where I work. And so for those of you who are new, those of you who have just joined the organization, bleeding disorders can be divided into two main groups. You have a group of disorders called coagulation disorders and another group of disorders called platelet disorders. Then among these, the coagulation disorders, the ones where clotting factors are deficient, and that too most commonly clotting factor A and clotting factor B, as in clotting factor 8 and 9, where causes hemophilia A and hemophilia B. They are the ones which have been traditionally recognized the most. And that because they are X-linked disorders, for a long time, people thought that these bleeding disorders happened only in boys or it happened only in men. And that is why this whole idea, this whole resurgence of women can bleed has come back now, because we have now recognizing that there are so many other conditions other than A and B, which can also cause bleeding, which includes rare bleeding disorders, which includes von Willebrand disorders, which include platelet function disorders. So all of them have equal men and women predilection, so they can bleed. And second, we have also over the years recognized that this A and B, when we have a carrier status of A and B, those people, those women who are genotypically having one mutation and they are carriers of hemophilia A and B, they can also bleed. So women are equally likely to bleed as compared to men in von Willebrand disease, rare bleeding disorders, and inherited platelet disorders. And in addition to that, hemophilia A and B, when you are carrier status, then again a proportion of women who are carrying one gene which has an 8 or a 9 mutation, they can also bleed. So this brings up actually a bigger group of people who can bleed when compared to hemophilia A or B. So that is why we need to recognize them. And like Prem just mentioned, this year's theme, that is on April 17th, we celebrate World Hemophilia Day. So this year's theme for World Hemophilia Day is Women and Girls Bleed Too. So again, you can see the hashtags that we bleed too, and there's so many other hashtags associated with women bleedings. We'll come to it in a bit. So why is it important is that, so this is something called as a no man's zone when nobody's really interested in it, right? So if you have a woman who is bleeding, it is very difficult for that woman to get to a proper healthcare system and to get a proper diagnosis compared to that of a man. And this is not just for India. It is true for globally. It is true for Canada also. It's true for US also. Because first of all, women probably underreport their symptoms. They'll think that those, okay, menstrual bleeding. First of all, there may be a stigma to talk about it. So they'll think they don't need to come to a hospital. This is something normal for me. So we have seen children girls come in with hemoglobin of 1 and 2 after heavy menstrual bleeding, because in the previous bleeds, they've never reported it to a healthcare, reported to parents or reported to healthcare facilities, and ended up getting a delay in reporting to a doctor, delay in getting a diagnosis. Second important thing is, a lot of these disorders we are going to see today, like for example, von Willebrand disease, have other affected members in the family. So many of you who are having VWD would know that there will be sisters, there will be mothers, cousins who have the same condition in the family. And all of them have been having heavy menstrual bleed. So they think that, okay, this is something which is normal for my family. It is not something which is unusual. So I should not be talking about it. And even if it is there, it is considered as a stigma to talk about menstrual bleeding or bleeding as such. So then there is a delay to a hospital. And whenever you reach also for menstrual bleeding and all, if at all you go to a doctor, you get to a gynecologist. So overall, people know what is fibroid. People know what is PCOD. Even in urban communities, if you get to a hospital, this is all what they think of. They don't think that there could be an underlying bleeding disorder. So to reach a hematology service becomes even further delayed. And now if you have reached a reasonably big hospital also, say, where you're seeing a physician or a pediatrician for this condition, to get to a diagnosis of von Willebrand disease or something like that, a rare bleeding disorder, say for example, factor 13 deficiency, none of the usual screening tests will show up, as in will be abnormal. For example, platelet count, PT, APTT may be normal in all these conditions. So again, you need a specialized hematology laboratory to diagnose it. So these are reasons why people report late, and this is not just for our country or low and middle income countries. It is for the entire world that people are reporting late. And now World Federation of Hemophilia has made a very active effort to report women who are coming in. So out of this year's age, like if you see the 2022 annual global survey, they have reported that there are around 100,000, that's 1 lakh women across the world who are bleeders. And of this, 50,000 would be VWD and the rest would be hemophilia, other bleeding disorders, etc. And then, as we discussed earlier, most of these disorders like rare bleeding disorders and VWD will be male and female is equal actually. But if you look at other numbers of patients that we see, so in my center, currently, say around 900 odd hemophilia A and B, we'll have some 25 VWD. So you imagine how the reporting is so less to a hospital service. So it's not like for every 900 hemophilia, there may be more VWD in the community, but they're just not coming to the hospitals. They're either having very mild disease, so they think that it's not important, or they have severe bleed. They may not have, there's such severe bleed, they may not have even survived, or such severe bleed and they've been taken to probably another specialist who did not think that the patient should be referred. So this is the delay in reporting, and this is something which results in a lot of health issues for the women also. So how do women present with bleed? One and the most important one which we'll discuss today is heavy menstrual bleeding. So menarche onset menorrhagia is the terminology that we use. Medical terminology for this is menarche onset menorrhagia. Menarche means beginning of menstruation. So at the beginning of menstruation itself, if somebody starts having heavy bleeding, like you would have heard of other causes of menstrual bleeding, like fibroid, for example. So fibroid is a very common, I think fibroid has even a local regional name in every community also. It's something very common. But fibroids don't develop in a 12-year-old or 14-year-old girl, right? So fibroids come with time. So in a typical history would be that the patient had bleeding normally, and then around 30 years or 35 years of age, then she developed a fibroid and she started bleeding heavily. So the original bleeds, the first few years of menstruation went off without any major issue. Whereas in our conditions that we discuss, so if it is a bleeding disorder, then it's usually bleeding will be heavy from the onset. And that is something which we have to teach our students also. We have to get awareness among our gynecologists also, that if somebody is coming to you with this kind of heavy bleeding from the beginning, from an adolescent age group, a girl who is coming in with heavy bleeding, so much so that you have to give transfusion, so much so that you have to give iron for that. That means that the child requires a evaluation for underlying bleeding disorder. You can have bleeding during pregnancy. You can have bleeding during delivery. You can have bleeding with in between cycles also. So I'll just show the cycle first so that we understand it. So all of us, when we have a menstrual cycle, you have two parts to a menstrual cycle. So the whole menstrual cycle is revolving around a ovum which is released from the ovary. The ovary sheds a follicle, a mature ovum from the follicles. So this middle part is the ovulation part of it. So this is the entire cycle of say around 28 days or so. Here the first 4 days are menstruation, and then the uterus slowly starts growing its thickness, and somewhere in the middle the ovum is released from the ovary. And after this, then the uterine lining increases a bit more, and then it starts shedding, and that's how the next cycle of menstruation happens. So this mid-cycle, when the ovum is released from the ovary, so this part of it, like this is the ovary which we have. So if you have any doubts, I can explain it later also. And I'm keeping the languages in English because that I see a lot of people who have joined from different parts of the country. So I'll try to make it as simple as possible. So this is the ovary from where our ovum is maturing. So this is how it gets matured. Out of hundreds of follicles, one of them will start getting mature, and then it gets released. This release process, no, for us, it does not cause any pain at all. So on the day 14 or so, it is released. Most women don't even know that there is something this is happening. But girls who have bleeding disorders, like von Willebrand disease, for example, factor deficiencies like factor 5 deficiency, factor 7 deficiency, they all can have bleeding during this small rupture process also. And it can be sometimes so heavy that if this is like your uterus, and this is your fallopian tube, and this is your ovaries. And from here, you can have a small follicle which is to rupture. Instead of small follicle rupturing, it ends up becoming a big hematoma there. It's called a blood into a corpus luteum, or it can be even, it can rupture further, causing bleed into the cyst can be there, or it can rupture further into the abdomen. It can cause hemoperitoneum. So this is a symptom again in girls which can present in between cycles. So your menstrual cycle is there as it is, it's prolonged and difficult. And once the menstrual cycle stops also, within like the next 10 days or so, another bleeding can happen. And this hemorrhagic ovarian cyst can be painful. It can be at times very life-threatening also if it's a very severe bleed. Like we recently managed around, I think a month back, a von Willebrand disease girl who came in with, so she was on regular treatment, but after a while she stopped the treatment on her own, thinking that this is enough and this is not needed and all, and she ended up with a very bad bleeding and a peritoneal bleed and all that. So these are reasons why it is important for you to know as well, because you don't stop treatment, because this is ultimately being given in the best interest of the child or the best interest of the patient. You need to get through your this part of it so that you can focus on academics, focus on life, focus on how to move ahead, have a career, etc. Right? So, but medication when prescribed has to be adhered to. And then these women can also have more miscarriages. When you marry, when you're trying to have a child, you can have more abortions. You can have pregnancies till term, and then after delivery of the baby, you can have bleeding after that also. So you need to know all these things. Huh? Why I'm telling stories also is because you remember them. Because we had a girl, lady who was actually she's the mother of a hemophilic. Okay, the boy. Well, I have been seeing him for many years now, and she comes every time to me. So then, when she conceived, we sent her to a gynecology department, and she knows she's a carrier and all that. And unfortunately, that baby was affected, and they gave them the option to have a termination, and she opted for the termination. And she went into the gynecology department for a termination. She never told the doctor, and as in it was probably presumed that she knew that she was a carrier, and she expected the doctor also to know that. And she had an abortion, and after that, she bled very heavily. And in the same hospital, as in there's a hematology department also, but she never told the gynecologist, and neither did the gynecologist think that it was important. And she ended up receiving lots of blood, loss of plasma, and all. Just in a simple dose of factor 8 would have just stopped her bleeding, but they never told. So that is why whenever you are going to undergo any healthcare, any medical intervention, then definitely inform. So even the bleeding phenotype women will definitely inform. But otherwise also, if you are a carrier and not had any major bleeding also, please inform your doctor if you're going in for a surgery, if you're going in for a procedure, even if it is a dental extraction, do inform, because we need to be aware of our disease process. We need to know what we have and need to have control over the situation. Women can also have joint and muscle bleeding. They can have deep bleeds, like bleeding, the blood in the urine, blood in the stools, etc. And they can also have gum bleeds, mucosal bleeding, etc. So this menstrual bleeding is a very, very important part of this whole bleeding process. And of all women globally uh, who have heavy menstrual bleeding, around 17 to 20% of women. So 1 in 5 of those women globally who have heavy menstrual bleeding can have underlying bleeding disorder. The other way around also, if you take 100 women with von Willebrand disorder, 80 women will definitely have heavy menstrual bleeding. So, yeah. So diagnosing diagnosis is quite delayed. So because of that, this is again the other hashtags that I told you. So globally, it is quite delayed. Okay, so it's not like it's delayed only for India, but globally, people don't report to a hospital. So there is something called a bad score. I'll talk about it a little bit more in detail later. So von Willebrand disease, we'll talk about what these disorders are, one line about it. Von Willebrand disorder is the most common bleeding disorder for all of us, men, women alike. But majority of these von Willebrand disorders are milder disorders. Okay, so because of that, they do not manifest as in they do not manifest with severe symptoms, and hence these people don't come to a hospital commonly. Majority again are autosomal dominant disorders. So you can have family history. So somebody with a mother who's had bruising and heavy menstrual bleeding can have a daughter who is having the same symptoms. So if you know of people like that in the families, please get them tested. Very, very important. The ones who are probably already know that they have von Willebrand disease, like our 25 patients, I think almost everybody is type 3, because the ones which are severe bleeding only, they're coming to a hospital, and those behave like exactly like hemophilia. So it's not their joint bleeds are very severe, and they can have, even when the girls start bleeding, they come with heavy menstrual bleeding very commonly. And again, like I said, it's little difficult to diagnose. Now, for a longest period of time, we thought that hemophilia was only for boys. So again, all the earlier textbooks, everything is written boys with bleeding, boys with bleeding. So now, over the years, we have realized that it's not so. The 2/3 of these, so in families with hemophilia, so 100 families with hemophilia, if you see, 66 of 70 people will have a family history, right? It's come from the family, there is a carrier in the family, and from the carrier, it has gone further down. So these carriers are what we are talking about today. So these carriers, earlier we used to think that they're not symptomatic, they don't need any treatment, they don't bleed, etc. But over the years, we've seen that even among hemophilia carrier, you can have people who have factor level less than 1%, in carrier with a 1 to 5%, and patients with a value between 5 to 40%. So again, just because if there are mothers who have joined in today who have children with hemophilia and you know your carrier status, you should get your factor 8 level done, because you may not be always asymptomatic, so you can have a level which is less than 40, and this you need to know, because if you are going through a procedure, if you have an accident, God forbid, something like that happens, then you need to know what treatment you should get. So this is the latest classification that's been presented in multiple forms, but the gist of it is that you should get your carriers, you should get your factor level tested, because if a factor level can be anywhere in between. It can be from 0, it can go up to say 50-60%, but still that value, it is important for us to plan medical interventions for you. And this is the ISTH BAT score. So I've put a QR code, I hope it works. So the QR code, if you can go through the scoring, it will take you to a bleeding assessment tool for the ISTH. It's a very simple screening test. So any one of you, if you encounter people who have had slight bleeding and do not know whether to investigate, not investigate, if you go through the scoring and then go through and take out the score and see. So if you have a score, if you have a if you're an adult, if it's above 18 years of age, your score should be above 6 or more, then you should get to a hospital and to evaluate. So these are the, and when do you think menstrual bleeds is important? If you are bleeding, this is a normal bleeding pattern, right? So it starts around 12 years or so. Normal interval is between 28 days to around 42 days. So usually it is 28 to 35 days. Sometimes it can be as short as 21 and as long as 45. A lot of girls, when they start menstruation, have irregular periods. That's completely normal. A lot of people can have bleeds which are lasting for 7 days, 10 days. Normal women, normal girls can have that without any bleeding disorder also. And every day, even in the heaviest bleeding days, you will probably change around 5 to 6 pads. So this is what is normal. But when you have abnormal, if you have, like I said earlier, when you have menarche onset menorrhagia, so from the first time you have had bleeding, you have had very severe bleeds. So that is abnormal. If you have had family history of mother, sister, anybody in the family, aunts, anybody having heavy bleeding, that is abnormal. If you have bleeding other sides, if you have gum bleeds also, if you have bruises also, then again this bleeding is abnormal. You have to evaluate. And then if you have associated menorrhagia, which is very difficult to control, if you're going on oral iron, if you have to get blood transfusions, etc., it is abnormal. And medically also, we look at something called a pictorial bleeding score also. So this score, again, very easy to calculate. So these are the days of your menstruation. This is when you're using a pad. And you can easily say in a day, how many pads am I changing? So day 1 of bleeding, maybe you're changing 3 pads. Day 2 of bleeding, maybe you're changing 4 pads. So one pad will look like this, another pad will look like this. So that kind of scoring you can make for yourself and see how this is. And if a score comes to more than 100, so if you have changed during a menstrual period, if you have changed say 4 pads like this and 3 pads like this, that is 100. And then that is equivalent to more than 80 ml of blood loss in every cycle. And this is very important to calculate. Nowadays, you can directly measure if you're using vaginal cups, but then many people are not comfortable using it. So that is again little difficult. But the crux of the whole thing is anybody has a heavy menstrual bleeding, get them evaluated by a hematology colleague, because it's many a times gynecological evaluation was only for the gynec issues like endometriosis or fibroid or things like that. So if it is not getting controlled on that, you have to go ahead and treat them. So how do we treat? We put all children on 9. Very, very simple regimen of managing menorrhagia. We start what is called progesterone only pill. So what does it do? This progesterone only pill, the progesterone only pill slowly makes the whole menstrual cycle anovulatory. So there is no ovulation as such that is happening. That ovulation part where the ovum is coming out, that part is not there. So it does not have any long-term effects on childbirth. Like later, if you want to have a baby, you can stop this, you can switch to other ways of controlling bleeding, and then you will regain your ovulatory cycles will come back again. So when you start this, your endometrium starts slowly becoming thinned out, and slowly the bleed process gets controlled. So we usually give 21 days of these pills and 7-day break. And in that 7-day, we give tranexamic acid, and that's how we have been managing. So quite a few patients with rare bleeding disorders also, some hemophilia carriers, some von Willebrand disease girls, and then many other hematological issues like your platelets are low, Glanzmann thrombocythemia, all of them are on the same regimen, and it actually helps by reducing the menstrual cycles itself. In the Western countries, there are other treatment options like DDAVP, um, other medications also that are available. Something which is available in India also is called this kind of levonorgestrel releasing intrauterine systems. So if you don't want to take a tablet every day, this is called Mirena, I think. So it is, you go to a gynecologist, you can ask them for an intrauterine device, which will actually happen, it will help you in contraception also. So if you're already married, you are desiring contraception along with it, then you can use this, where it will, this is a hormone eluting kind of system. So it will elute also, it will locally reduce the bleeding definitely, and it offers the advantage of having contraceptive action as well it will give you. So these are two things which are very popular and very useful also for people who have heavy menstrual bleeding. So in pediatric patients, we use as an adolescent girls who are unmarried and all, we use progesterone only pills to start, and then slowly once they reach that age, then we can tell the gynecologist, okay, maybe we can change to later. What happens in these women when they become pregnant? So again, pregnancy is another issue, which is, so when you have a heavy menstrual, as a woman bleeder who is got married and is desirous of having a child, here again, we have to manage a lot many things. So first of all, the whole issue about genetic counseling and whether it will go on to the next baby and the next pregnant, next generation, etc., that you have to definitely discuss. But other than that, in between the managing the pregnancy, you will need factor support during that period, you will need iron during that period, and you will have to stop these hormonal medicines at that point of time. Many of them go through pregnancy without any difficulty. For example, type 1 VWD, generally von Willebrand levels increase in pregnancy, so you go through it. Mild hemophilia A goes through pregnancy without any difficulty. But some of the deficiencies, like for example, fibrinogen, factor 13 deficiency, type 3 VWD, it's again a little difficult because miscarriage rates are very high in these things. So you have to be on factor replacement during the period of pregnancy, so that you don't have a abortion that is happening. What happens at childbirth? Again very important for families with hemophilia, let's say. So you have one child with hemophilia, you have gotten yourself tested for the next baby, the baby is not affected, you have decided to go ahead with pregnancy. But here again, and the next pregnancy, when you are going to give birth, you should tell the doctor that I am a carrier of hemophilia. So although this baby is not affected, still I can bleed. So that the doctor has to take care. So what we do check is, we check the level of factor 8 closer to pregnancy. So factor 8 and 9 are there in hemophilia A and B, that is the deficiency. 8 levels usually increases. So 8 levels you don't need to supplement at the time of delivery. By third trimester, that is like a 7th, 8th, 9th month of the pregnancy, it will increase. So it's easier to control 8 carrier state, but 9 does not increase. So you may have to, if you're during pregnancy, that at the end of it, that at the delivery when it is approaching, you have to check your factor levels and you have to decide whether you need to give any treatment or not. So this is a whole series which I have said there. There are around, out of 100 women, the 3%, normally people bleeding is just 3%. So 100 women going to a hospital to deliver, only 3 will have postpartum bleeding, that is bleeding after childbirth. Whereas you see in hemophilia, the rate will be 20%, 11%, 6%, some rates of even 38%, 35% bleeding. So one third of women who are going to a hospital, one third of hemophilia carriers who are going to a hospital to deliver a baby will have bleeding. So that is a very, very big number for us to deal with. So always remember that you have to tell the gynecologist. So there is nothing to be stigmatized about it. It has to be informed. So this is something we'll routinely encounter. That's why I'm telling again and again So please inform your status when you are in a hospital. Don't think that it is all normal and this baby is normal, so I don't have to worry about myself. That is not the case. You have to worry about your health as well. The third thing I mentioned is hemorrhagic ovarian cyst. So I showed you how the ovary, the cyst is formed and how it can bleed. So how do we know? So VWD women or girls, rare bleeding disorders like Glansman or factor 5 deficiency, 7 deficiency, all of these girls, if they complain of severe pain abdomen, it does not happen at the menstrual time. So you don't have menstrual bleeding at that time. This is in between menstrual cycle, almost in the middle of it, sudden pain abdomen, vomiting, there can be severe bleeding into the abdomen. So you're not seeing the bleeding. It's just that pain abdomen and fever, sweating. If you're losing your BP is falling, this is all features of peritoneal bleed that has happened. Again, very, very important. So I know few of the people in this women's group who were having this. So for easy for us to manage as in von Willebrand and all, it's little more easy to manage. For factor 5, 7, etc., it becomes a little more difficult to manage because you don't have good factor support for that. You are dependent on plasma mainly. So you can't increase the level beyond a point. So these girls, if they are anyway, and you know them and they're coming in contact with you, get them to a hospital immediately, get a blood test done, CBC done, look at the hemoglobin, you need to transfuse them. You may need to give factor, you may need to give FFP cryo, all that is also important. Sometimes you may need to even operate and remove the clot and remove the area which is bleeding. Easier said than done because in a bleeding disorder, anyway surgery, that too major surgery like abdominal surgery and all, doctors will be very, very hesitant to do because it's a life-threatening procedures. So these are specific types of bleeding that you need to know about. So that we discuss delivery a bit also, postpartum bleed. How long can you bleed postpartum is normally around 2 weeks in a cesarean section and 1 week in a vaginal delivery. So this again, you have to be aware that this bleeding can happen. You should be on specific treatment like factor 5 deficiency, what you can give plasma or factor 5, these are the treatment options that are there. 5, 7, 10 deficiencies. Factor 13 deficiency, we usually give cryoprecipitate or factor 13 concentrates. 5+8 deficiency, usually FFP is what is given for these girls. And now, couple of more things like in pregnancy, the hemophilia delivery we discussed, platelet function disorders. So there are people who have Glanzmann's thrombasthenia and then Bernard-Soulier disorder. So these are disorders of platelet function. So they also come under the rare bleeding disorder category also. What do we give them for treatment? We give them platelet transfusions. But then after a while, the platelets, if you give somebody else's platelet, no, it does not rise the platelet level at all. So then you are stuck. So in these conditions, if you are encountering this kind of bleeding, what can you give? You can give factor 7A. So 7A is an option, and then certain other treatment options are also coming up in this group of disorders. Does the baby have bleeding? The baby immediately, unless the baby is affected, the baby may not have bleeding. The baby, whether the baby is affected or not, you would have already checked. So that also is not an issue. I kept on saying that it's not the case only in India because I think wherever we go, we hear the same thing that these bleeding disorders are so rare that during our training for becoming physicians, pediatricians, or gynecologists, the awareness regarding bleeding disorders is very less. So actually, don't need to blame the doctor that the doctor did not check because this disease is so rare. So if you have a symptom, get to a specialist doctor because many a times gynecologists or pediatricians or physicians would not have managed or would not have even seen a patient with von Willebrand disease or maybe factor 13 deficiency, etc. in the entire career. I wanted to also show we did a survey along with the HFI in 2016 prior to the World Federation of Hemophilia meeting, where a lot of you were part of this survey. So this survey was subsequently published as an abstract in Hemophilia. So we interviewed 175 women from across the globe on this project called Women Can Bleed Too project. It was a social media campaign which was launched. A lot of you were part of this survey in conducting the survey also. So we saw majority of women who replied, as an of the 175 women who replied, around 50% were VWD and 20% were rare bleeding disorders. Another 23% were hemophilia carriers and 74% had a severe bleeding phenotype. But they said that their timing of reporting to a hospital was 8 years. The average time to reach a hospital was 8 years. So whether it is in India as well as in other middle income economies, low and middle income economies, the average time from onset of bleed. So you have starting bleeding say at 12 years of age, you'll probably get a diagnosis at 20 years of age. This was the status. Now it's almost 8 years after that study is finished and published, but still you think how how delayed it is. So these kind of meetings, these kind of webinars, this kind of way it is being, streamed, and it's available for viewing later also. So these kind of educational activities, when you do it in your local areas also with your team of doctors and team of specialists, it will definitely help improve awareness regarding the conditions. And you can here also see that the first diagnosis was wrong in 67% of the patients, and the bleeding was severe. Most of them had a lot of impact in that as well. So similar studies were done in other countries as well. So this is another study from US also on carrier women and how frequently they are going to the hospital. It's not that they don't know that they are actually going, and you say we think that carrier women are asymptomatic. It is not the case. So a lot of healthcare is being, expenses are there in these women as well. Not just bleeding. Many of them will have chronic pain. Many of them will have bony issues, etc. And I'll finish with a paper which we just published in last year on the quality of life of women and the bleeding profile of women who have hemophilia carriers as well as other bleeding disorders. So in this small work that we did, we have two groups of people now, two groups of women. One group of women who are mothers of the hemophilia children who are coming to our hospitals. Okay. So none of them told us that they have bleeding. They just come to show their sons. So, and every time they come, we treat their sons and send them. So we never ask them whether you have any bleeding. Okay. And the other group are girls whom we know bleeding, like VWD girls or girls who have rare bleeding disorders, etc. So we did the same survey for both these group of people. So we have 68 women with hemophilia genotype, that is carrier women, and 12 girls with VWD or RBDs. And then we looked at their bleeding profile. So if you can see, it was very shocking for us. So out of this 68 women, no, 30% had a bleeding symptom, which they never told us. So they've had menorrhagia, they've had antepartum hemorrhage, they had postpartum hemorrhage, some had ENT, nose bleeds, some even had abdomen bleeds. They never told us that they have a bleed. So when we asked them, that is only when we got to know. And when we look at the EQ5D-5L, which is the quality of life score also, their pain, their anxiety, their depression was actually comparable to women with von Willebrand disease. So just imagine how severe is the phenotype. One side we already know, like a factor 5 deficiency, 7 deficiency, a factor 13 deficient girl or a VWD girl will bleed, we know that. But we never expected that a carrier lady will have a similar quality of life, as a poor quality of life as we were expecting. So this was an eye opener for us also. So we're trying to carry it forward as a bigger study to see how we can improve their bleeding profile and get them to get evaluated very quickly. So I'll stop here by saying that awareness regarding bleeding is very crucial at all stages of life in both men and women. So it's no longer only men who suffer from bleeding. Women have, and we saw all the different diseases where women can have bleeding, all the different conditions where they can have bleeding, and all the different types of bleeding they can have. So if you are having, or if you know somebody who has a similar condition, definitely get yourself to a hospital and get yourself tested quickly. And this is the 2016 HFI Women's Group meeting. I think this was the first national, meeting. A lot of international participants also. I think many of you will be here in this group. I'll stop here. I'll be happy to take any questions.
Yeah, ma'am, there are a couple of questions. Before that, I would thank you for such a wonderful session, very informative. And also, there were many new participants who had very small kids. And we come across the parents who are from first year or from 6 months old kids. So they have those thought process that how this could be, why am I, and all. So I think this would be an answer for them. So first question here is, which is the second method if not pills?
So if not pills, then the second method, usually the most comfortable method would be to use. Like if you're married and if you're okay with having a intrauterine device, it would be that neonatal intrauterine device like Mirena, which is quite gynecologists prescribe it. Otherwise, also for women, that can be used. If you're not comfortable for that, then the same progesterone which we're giving as a pill, you can give it as a depot preparation. So it's a small thing that comes, you can inject it under the skin and it will remain there for many months together. So then also you don't have to take pills daily, but the mechanism is exactly the same. So if you don't want a pill at all, you don't want that medication at all, then it becomes very difficult. And then you will have to resort to getting prophylaxis, etc. Like von Willebrand factor, for example, von Willebrand deficiency. If you are not been controlled on this, then the only next option would be to give prophylaxis. And imagine so much a factor going in as prophylaxis. It's extremely difficult to get it also, and an extremely difficult, and your quality of life actually will come down a lot because you have to inject it, and as in during the duration of menstruation you have to inject it and things like that. But if you're on a pill, your cycles will become shorter, and cycle also, when you stop the medicine also for 7 days, your bleed will be much lesser than what it used to be. So because of it, it's much easier to manage that way. And no real very long-term side effects are not there.
Okay. And if we take oral care pills for lifetime, is there any issues or is it okay?
Yeah, so this is something which is extremely worrying for everybody, that if you start this medicine, what happens? Will you be able to have, conceive later, have children later, etc. So progesterone only pills are safer from that aspect, that you, as in during the time when you take it, definitely, but once you stop, then you regain your ovulatory cycles again. So that way, long-term effects are less. Second is, we are taking progesterone only pill. We are not taking that Maladi kind of estrogen plus progesterone combination. So because of that, that risk of thrombosis, etc. So when you are on estrogen plus progesterone pills, there are some clotting issues that can come. So even if you are a bleeding disorder, you can still have clots formed. So that risk is less if you take progesterone only pills. So what we advise is you start, and then when you are desirous of a pregnancy, when you are getting to that stage, maybe you see all your options, what are your options, what prophylaxis can you get, and things like that, and then switch to at that point of time and take it. If you're not having too much of difficulty taking a tablet, switch to a depot preparation or an intrauterine device.
Okay. Do cysts often regularly be there at a particular ovary? Will that be regularly recurring?
Every month. That happens for everybody. So everybody will have, if you are in that menstrual period, but like women start menstruating around, say, 12 to 14 years now, and initial few cycles may be anovulatory. After that, the periods when they become regular, there will be ovulatory cycles. So every cycle will have an ovulation. That formation of that maturation of this follicle will be normal. That is a normal process for everybody. Till the time you are reaching your menopause, this is going to happen. Only period when you don't have it in between is when you are pregnant. But that rupturing causing a hemorrhagic cyst is not normal at all. And that cyst bleeding into the cyst happens in bleeding disorders only. And this is not PCOD. This is not ovarian cyst that you see in PCOD, or that everybody knows these days, what is PCOD or PCOS, etc. So this is not that exactly. That is a hyper stimulatory, lot of follicles developing in the ovary. That's a slightly different condition that happens because of lifestyle issues, that happens because of weight gain, sedentary lifestyle, insulin resistance, a lot of things going into that. I'm not talking about that. I'm talking about a normal menstrual cycle where one follicle has to be matured and ruptured, but that rupture is causing a bleed in a bleeding disorder.
Okay. So do OC pills example ovarian, which can cause PCOD? That is what they have asked. Which leads to
No, actually,
PCOD.
yeah. So treatment of PCOD, like you will, even this can be offered as a treatment. But thing is, there are many other treatment options like, healthy lifestyle, etc. for PCOD. So this does not cause PCOD, if that is the question.
Okay. They're asking ovary removal कर सकते हैं क्या?
Yeah, but then that still, So this is something which a lot of girls have asked me, ki how do we stop this? Mala, how can we stop having menses once and for all? So that is something which has a lot of other health implications. You know, when you stop having menstrual cycles, then your effect on your health as such will change. Your thrombotic risk changes, heart attack risk changes. So these are all, you know, during the active fertile period, you menstruation is there for the purpose. And after that, when you stop having menopause, etc., then your heart disease risk will be similar to that of men. Your bone disorders risk will be there, clotting risk will be there. So I wouldn't advise you to stop, remove ovary or remove uterus and stop bleeding once and for all. If it is very difficult, for example, like, you know, a life-threatening bleed which you're not able to control. I know a you know, girl who had inhibitor positive von Willebrand disease, who no factor level would improve her. So in such a condition, then it's only in such conditions that you wouldn't even think about it. Otherwise, there are so many safer options now. You don't need to get to thinking, you know, you don't have to think of something that radical.
Okay, VWD, autosomal recessive. Can you please explain it in short?
I didn't actually come to that genetics part of it actually. Uh, so, so von Willebrand disease is so there are disorders which are autosomal recessive and autosomal dominant. Let me see if I can pull out a picture. So, when the gene is carried into the next pregnancy, as in when you have a disorder which is inherited directly into the next generation, it is called autosomal dominant. Hemophilia is an X-linked dominant disorder. It is not like, I'm just projecting it 1 minute.
Ma'am, is there any advancement for factor 5? Because I get a couple of patients asking me that any advancement or something useful medicine is going to come for them.
Trials are there. 7 also there is a clinical trial, I think.
Oh.
So I had so there are these groups that are very active. So recently they were reaching out to patients.
Mm-hmm.
I think I have that email ID somewhere with me. I'll share it with you.
Yeah.
So I'll just share my screen again to show that autosomal recessive and dominant. Yeah. It's not very clear, but you can see that certain disorders are called autosomal dominant disorders, where the defect is as it is carried into the next generation. So even if the other spouse is completely normal, this if you have a mutation, that can go into the next generation completely, and it is a dominant mutation, and because of that, and it can happen in a boy or a girl. So you can have 50-50% chance of boys and girls being affected. Majority of von Willebrand disease is like this. So usually the mother will be, as in mother, if the mother is carrying it, the mother has the mutation. There is equal chance of the girl and a boy in the next generation to be affected. Autosomal recessive is when you have a mutation, you have two alleles to it. So here that picture is not there, but see here you have two sets of genes from your parents. One is from your father, one is from your mother. So say this is what we're talking about. So this is from the father and this is from the mother. So in this mutation, when there are disorders which are affecting only one side, so that is called a recessive mutation. And here that one mutation is shown as a dot. It is not completely shaded, it is just one dot. So if you have one dot only and your spouse is normal, then it does not go as does not cause disease in the next generation. It just goes off as a carrier state. So typical example is a thalassemia disorder. So here your parent is a carrier, you become a carrier. And when you marry a carrier, then both carriers are there, dot is there, then you end up having a baby, 25% chance of having disease. So this is type 3 von Willebrand disease, your autosomal recessive inheritance, which you see. And the third completely different group of disorder is called the X-linked disorder, so hemophilia A and B. Here if the mother is affected, and as in mother is a carrier, from her the son can become, since it is X-linked, in the son you have only one X, the other is Y. And because of that one X being affected, it becomes completely affected here. So if you have if say this is if this is hemophilia, this mother being carrier, you can have boys who are completely affected. Whereas if this is autosomal recessive, then you have to have a spouse who have the same disorder, and then there is 25% chance. So if you have a von Willebrand disease type 3, it is autosomal recessive. Then you have to check your spouse, and then if your spouse also is a VWD carrier, only then you have a chance of having a baby affected. Whereas if you are a type 1 VWD, it is an autosomal dominant disorder, then you are 50% chance of your children being affected with the same disorder. But type 1 von Willebrand disease is a much lesser symptomatic disease than type 3. So many of people don't even check also, they just go ahead and have children. Okay, and Devi has put out one recessive picture also.
Yeah. Does being a carrier causes endometrium thickening and delay in getting pregnant?
So miscarriages are known to happen in hemophilia A and B carriers. Delay in pregnancy, no, not as much. Miscarriages are common in other disorders like factor 13 deficiency. Miscarriages are way more common. Fibrinogen disorders, miscarriages are common. Hemophilia also miscarriages have been reported more, but delay in becoming pregnancy is not an issue. It might be because of other gynecological issues.
Okay. फैक्टर 10 में फैक्टर अवेलेबल ना होगे ब्लीडिंग कैसे मैनेज कर सकते हैं फॉर फैक्टर 10 इफ देयर इज नो फैक्टर हाउ कैन वी मैनेज द ब्लीडिंग
FFP. So like I said, if it's a woman who is bleeding, and if your bleeding phenotype is your bleeding is basically heavy menstrual bleeding, then you go ahead and do all this what has been discussed till now. Speak to your hematology doctor, speak to your gynecologist, put yourself with all these medicines. Tranaxa, iron. Iron is something which all women should anyway have it. So especially if you are having a heavy menstrual bleeding. So iron, Tranaxa with a progesterone only pill can help you manage bleeding to a major extent. So I have fibrinogen deficiency kids on that. They don't bleed only now. So that can be managed. But if you are having bleeds other than menstrual bleeds, like for example, joint bleeds, muscle bleeds, psoas bleed, that kind of bleeding, then FFP is the only option if you don't have factor 10 concentrate.
Is there any advanced medicine available for ephenogenemia apart from cryo?
Fibrinogen concentrate. Fibrinogen concentrate is now available. So I think it is rare in some state tenders also. Like for the state of UP, UP is purchasing fibrinogen for patients with fibrinogen. So that is available now. So you can give it as injection fibrinogen, just like a factor concentrate, you can give it as an injection.
Here is the question, maybe that is a little confusing. Can VWD patient who is not a carrier, will the future baby be affected?
Yeah, this is what I said. So VWD, you need to find out which type of VWD you are. So if you are a type 1 DW, usual type 1 is autosomal dominant disorder. Then in type 2, there is a certain variant which is X-linked disorder. Then type 3, you have autosomal recessive disorder. So first of all, you need to know which type of VWD you are. And once you know that, then you can discuss the future baby's risk. Type 1 VWD, 50% of future babies will be affected. But then type 1 VWD is not a very severe bleeding disorder. So you generally people think, okay, it is manageable, we'll go ahead with the pregnancy. But in type 2 and 3, you should be very, very careful. You should speak to your doctor and then get genetic counseling done, etc., to decide before you plan your next pregnancy.
Thank you, ma'am. Is there any other questions to be answered, or we will be winding up the session now? Okay. So now I request Sunita ma'am to give vote of thanks.
मैम एक
थैंक यू सर।
क्वेश्चन कर सकते हैं हम?
ओके, हाँ बोलिए।
मैम मेरा क्वेश्चन है, मेरी बेटी को वीडब्ल्यूडी है, वीडब्ल्यूडी पेशेंट है वो अभी तो छोटी है, 14 इयर्स की है। तो मैम क्या वो अगर फ्यूचर में जब उसका मैरिज होता है किसी के साथ, तो वो सामने वाला अगर पर्सन में कोई डिफेक्ट नहीं है, सपोज एकदम नॉर्मल पर्सन है, तो क्या ये जब बेबी करेगी तो वो बेबी इसके लिए मतलब सेफ साइड होगा कि मतलब डेंजरस जोन होगा कि लाइफ थ्रेटनिंग होगा, ऐसा कुछ? मतलब
एक
अगर
बार
वो प्रेग्नेंट होती है तो प्रेगनेंसी इसके लिए डेंजरस है कि मतलब मैम फैक्टर उक्टर देख के मैनेजेबल है?
क्या डिजीज था? टाइप 1 वॉन विलिब्रेन डिजीज,
वॉन विलिब्रेन टाइप 3।
टाइप 3 ओके। मतलब मैनेजेबल तो है डेफिनेटली, इट्स जस्ट दैट यू नीड टू हैव अ गुड सेंटर विद यू, गुड सेंटर, गुड एक्सपर्टीज होना चाहिए। गायनेकोलॉजिस्ट को भी पता होना चाहिए कि क्या चीज़ है, एंड हेमेटोलॉजिस्ट होना चाहिए, फैक्टर की सपोर्ट होनी चाहिए, ये सब है तो मैनेज कर सकते हैं।
अच्छा मैम, हम लोग जमशेदपुर में रहते हैं, तो जमशेदपुर में वैसे तो फैक्टर उक्टर तो मेरा हो जाता है, लेकिन मेट्रो सिटी नहीं है तो थोड़ा एक डर भी रहता है।
सबसे पास क्या पड़ेगा आपके लिए?
कोलकाता।
कोलकाता। कोलकाता में आप एक बार बात करके पूरा प्रिस्क्रिप्शन वगैरह ले लीजिए, फिर प्रॉब्ली डिलीवरी
हम्म
के टाइम पे वहाँ चले जाना, है
मैम
ना, ऐसे
अभी तो
मैनेज
बहुत
कर
देरी है, लेकिन एज अ मदर मेरे को वो बहुत टेंशन रहता है।
हाँ ऑफ कोर्स, बट तब तक मे बी देर आर बेटर ऑप्शंस आल्सो नाउ, तो देर इज डेटा ऑन वॉन विलिब्रेन डिसीज में मेसेसुमैब का डेटा आ रहा है ना, तो उसमें हो सके 5-6 साल में वो सब भी आ जाएंगे, तो ब्लीडिंग बिल्कुल ही कम होने का चांस रहती है। तो मैं एज ऑफ
हम्म,
नाउ के लिए बोल रहा है, जब तक आपका बेबी बड़े हो जाएंगे तो और भी
हम्म।
ऑप्शंस निकल जाए।
मैम ये जो प्रॉब्लम है ये कभी सॉल्व नहीं हो सकता है, क्योर नहीं हो सकता है मैम?
क्योर तो हीमोफीलिया ए और बी में क्योर की अभी टेस्ट वगैरह वो चल रही है, जीन थेरेपी,
हम्म,
आपने भी देखा
हम्म,
होगा, तो बाहर कुछ
हम्म,
कंट्रीज में हो रही है, इंडिया में भी अभी जस्ट पब्लिश हो रही है कि
हम्म,
ऐसे स्टडीज आ रही है। अब एक बार
हम्म,
हो जाएंगे, फुली फंक्शनल हो जाएंगे, अभी तो बहुत कॉस्टली भी होंगे अगर आएंगे तो भी, बट इवेंचुअली
हम्म,
वो धीरे धीरे उसके कॉस्ट भी कम हो जाएंगे, वो वन टाइम क्योर हो जाएंगे। बट वन मोर
हम्म,
इम्पॉर्टेंट थिंग इज जीन थेरेपी जहाँ होती भी है वहाँ पे भी
हम्म,
पेशेंट्स सब लोग नहीं जा कर रहे वो, है ना, क्योंकि आजकल
हम्म,
दवाइयाँ भी जैसे हीमोफीलिया ए और बी में आजकल बहुत सारे दवाइयों में भी एडवांसेस है, जैसे नॉन फैक्टर रिप्लेसमेंट आ गया या फिर एक्सटेंडेड हाफ लाइफ प्रोडक्ट्स आ गया, जिस वजह से
हम्म,
उनका लाइफ बहुत मैनेजेबल हो गया, तो फिर वो
हम्म,
सोचेंगे कि मैं इतना बड़ा एक इलाज क्यों करूँ जब मैं वैसे ही मैं ठीक हूँ, है ना, तो ये
हाँ हाँ।
ऑप्शंस आगे और डेवलप हो जाएंगे, तो
हम्म,
प्रोबेबली 4-5 साल के अंदर ही ई टाइप 3 वीडब्ल्यूडी में मिसेसुमैब का आ जाएंगे, है ना, ऐसे, या फिर
हम्म,
नए दवाइयाँ भी नॉन फैक्टर रिप्लेसमेंट और भी नए आएंगे अगले साल तक, तो ये
हम्म,
सब दवाइयाँ एक बार अप्रूव हो जाएंगे, ये
हम्म,
वाला जो हम अभी मैनेज कर रहे हैं वो चीज़
हम्म,
एक एक पास्ट हो जाएंगे, फिर नए ट्रीटमेंट आ जाएंगे, तो इट विल बिकम बेटर, तो क्योर की शायद ज़रूरत ना ही पड़े, बट
हम्म।
कंप्लीटली कंफर्टेबल, बेटर, मच बेटर हो जाएंगे सिचुएशन।
लेकिन मैम बहुत डर रहता है मैम, थोड़े थोड़े महीनों में उसके बॉडी में एचबी डाउन हो जाता है, आईएन की प्रॉब्लम हो जाती है, तो मैम हर समय मतलब एक अलर्ट रहना पड़ता है, कंसर्न रहना पड़ता है, मतलब बिंदास नहीं रह सकते हैं कि हाँ बस, मतलब एक टेंशन रहता है मैम, एचबी डाउन होने का बहुत चांसेस रहता है मैम, फिर हम उसके ब्लीडिंग के टाइम ओसी पिल्स भी यूज करते हैं हम,
नहीं,
बहुत बार
अंडरस्टैंड,
ओसी पिल्स भी देना पड़ती है।
नहीं नो, बट आयरन देते रहिए आप, ठीक है, अभी तो इस उम्र में मतलब छोटे बच्चों में ब्लड देने की ज़रूरत ही नहीं पड़ना चाहिए, आप आयरन देते
अच्छा।
रहेंगे तो ब्लीडिंग इतना कोई ज़्यादा ब्लड लॉस तो नहीं होना चाहिए, बाकी फैक्ट
हम्म।
जैसे जॉइंट ब्लीड्स हो रही है या वो सारे
नहीं
ब्लीड्स
वो
के लिए
सब नहीं
फैक्टर
होता है
लग ही
मैम,
रहे।
मैम ये वीडब्ल्यूडी में सबसे ज्यादा प्रॉब्लम ये मेंस्ट्रुएशन प्रॉब्लम ही होती है,
हाँ
मतलब मेन
गर्ल्स
पीरियड्स के
में
टाइम ही प्रॉब्लम, और एक होता है स्टूल, स्टूल में आती है मैम, मैं स्टूल में ब्लीडिंग होता है।
डेफिनेटली, बट बहुत सारे बच्चों को टाइप 3 von Willebrand's में जॉइंट ब्लीड्स भी होती है। तो
अच्छा।
मतलब स्पेशली लड़कों को, तो जैसे लड़के को ब्लीडिंग होता है टाइप 3 VWD, तो लड़कों में भी हो सकती है। तो
हाँ हाँ
उनमें
हाँ
स्पेशली जॉइंट मसल ब्लीड्स ज्यादा कॉमन है। स्टूल में ब्लड आ
हाँ
सकता है, वो मैंने आज डिस्कस
हाँ
नहीं किया, बट
हाँ
वो
हाँ।
पेट से ब्लड भी आ सकता है इन बच्चों में, है ना। तो
पेट से
स्पेशली
ब्लड
वो
मीन्स
जैसे
मैम?
बड़े हो जाएंगे, तो
हाँ हाँ
20, 25, 30 साल के होने लग जाएंगे, तो पेट के
हाँ।
अंदर से भी ब्लड आ सकते हैं। तो उसमें भी आपको जल्दी से जल्दी ट्रीटमेंट लेना जरूरी है।
तो पेट से ब्लड आएगा तो मैम स्टूल से निकलेगा?
हाँ, उल्टी में भी आ सकती है।
ओ माय गॉड। तो मैम कैसे मैनेज करेंगे उस समय?
नहीं,
ट्रेनेक्सा?
इतना मत सोचो, हॉस्पिटल ले जाओ। तो अगर स्टूल में
अच्छा
ब्लड वगैरह घर पे मैनेज करने वाली बात ही नहीं है ना, तो आप हॉस्पिटल
अच्छा।
जल्दी से जल्द पहुंचेंगे, डॉक्टर चेक
हम्म।
करेंगे, क्रायोप्रेसिपिटेट या फैक्टर देंगे, ब्लड चढ़ाना है
हाँ
कि नहीं
हाँ।
देखेंगे, वो सारा चलेंगे। बट अभी जो
अच्छा।
मेंस्ट्रुअल ब्लीडिंग है उसमें ब्लड देने की जरूरत नहीं पड़नी चाहिए, अगर मैनेज हो रही है। ये सारे जो
हाँ हाँ
प्रॉपरली मैनेज होती है विथ ओसी
हाँ
पिल्स एज वेल एज आयरन ट्रैनेक्सा, तो ब्लड चढ़ने
हाँ
की
हाँ
बिल्कुल जरूरत नहीं पड़नी चाहिए।
हाँ हाँ हाँ
ठीक है।
हाँ। ओके मैम, थैंक यू सो मच। मैम हम लोग की फैमिली हिस्ट्री में कहीं किसी को कोई ना हेमोफीलिया है ना VWD है। उसके बाद भी ये कैसे हुआ, कहाँ से आया, कुछ समझ ही नहीं आ रहा है।
जरूरी नहीं है ना, फैमिली हिस्ट्री सब में जरूरी नहीं है। तो von Willebrand डिसीज स्पेशली ऑटोसोमल रिसेसिव डिसऑर्डर्स में कभी भी जरूरी नहीं है कि फैमिली में और किसी कोई अफेक्टेड हो। बहुत सारे लोग कैरियर
हम्म,
रहे होंगे, कभी आपके केस
हम्म,
में ही वो पहली बार वो अफेक्ट हुआ होगा।
अच्छा। थैंक यू सो मच मैम।
ठीक है।
If
ओके।
there are any other questions, we'll take two more questions and then we'll wind up, because this webinar was up to 9 o'clock, but still we extended. The other questions can be directed to support@hemophilia.in. One or two questions will be taken. So please. Anyone
There
wants
is a
to?
question, Indra ma'am, on physiotherapy, muscle strengthening, etc. तो डेफिनेटली वो
हेलो
बहुत ज़रूरी है, सबके लिए ज़रूरी है, जिनको भी ब्लीडिंग होती है और जिनके वैसे भी ज़रूरी है सारा। उसके अलावा women should also focus on exercise and keeping yourself fit, that is one thing. बट जिनके जॉइंट ब्लीड्स हो रही है तो उनको और ज़रूरत है फिजियोथेरेपिस्ट या रिहेबिलिटेशन स्पेशलिस्ट की, तो उनको दिखा के प्रॉपरली मसल स्ट्रेंथ बनाए रखेंगे, तो जॉइंट ब्लीड से रिकवरी जल्दी हो जाएंगे, जॉइंट ब्लीड्स का ओवरऑल परसेंटेज कम हो जाएंगे। तो किसी ने पूछा एंटी फाइब्रिनोलाइटिक्स, so antifibrinolytics is tranexamic acid which I am talking about. So definitely it is, other than this oral contraceptive pills, iron is very important for everybody who has a bleeding issue. Its iron is very important for all women, so whether bleeding not bleeding, so you have to take that. And second medicine is this hormonal pills that we said, and third is tranexamic acid, वो ही है antifibrinolytics. So you can use tranexamic acid whenever there is a bleed. So not just menstrual bleed, you can take it in oral bleeds also. You can put it as nose drops if you have epistaxis. You can take injection tranexamic acid and take 1 or 2 drops and put it inside. That also helps control local bleeding. So it is very effective in all these bleeding disorders.
Hello, ma'am. There was only one question regarding VWD. I'm a patient of VWD. So I
Tell me.
We can't hear you.
I didn't understand the question.
ma'am, I'm a patient of VWD type 3. So just I want to just a small guidelines from you. I just want to plan my pregnancy, but I'm having a recurring cyst at a left ovary or the right ovary, and I had a menorrhea also, bleeding, also internal bleeding. So now I'm on OC pills. So now they are telling like to wait for some few months. So what should be done like after that? Is it manageable? Is my pregnancy manageable, or any other options I should take? Go ahead with it.
Generally, how is your bleeding otherwise?
My bleeding is normal. When I bleed for during my menses, also my menses up to 7 days. First 2 days a little bit heavy. 4 days are normal without tranexam.
You're not taking any prophylaxis also, 1 milligram
No,
factor
no, nothing.
prophylaxis.
Till date, nothing.
Okay. And you're type 1 VWD?
No, I'm type 3 VWD.
Type 3. You can give it. So if your bleeding is not very severe, as in you are managing otherwise, you can go through pregnancy. You just have to have a factor available with you during this thing, because you cannot take any other medication during that time. No? You can take Tranexa and you can take iron, but you cannot take any OC pills at that time. So because of that, you should have access to 1 milligram factor.
Yeah,
So that
during ovulation time, is it necessary to take factors?
So currently, are you on hormonal contraception?
Yes, yes, I'm on overall G.
Okay. So when you before you used to take overall G, you must have had bleeds, no? You must have had bleeding during ovulation. Have you had that?
Yes, yes, yes. 2 episodes I had.
Better to take factor then. Better to take
Okay.
factor cover when you're planning a pregnancy. And then once you become pregnant, then in the initial first few months also, you may require, they will check the factor 8 levels and decide how much to continue. And then during the delivery period, definitely you will require.
Okay, ma'am. Thank you so much.
Thank you, ma'am.
Yeah, so over to Sunita ma'am for vote of thanks.
Thank you, Indra ma'am. Thank you, President sir, प्रेम सर, उनको धन्यवाद दूंगी क्योंकि बिजी ट्रैवल टाइम में से उन्होंने हमें टाइम निकाल के यहाँ अटेंड किया सेशन, तो उनको बहुत बहुत धन्यवाद. हमारे वीपी फाइनेंस जगदीश जी और रामू जी को भी थैंक्स, एंड ऑल ईसी मेंबर्स, हमारी सारी ईसा मैम, जो कि हम सभी हीमोफिलिक्स बच्चे उनको सबका ध्यान रखती हैं दिल्ली में तो बहुत ज्यादा. और आज का सेशन जिसमें कोई भी पॉइंट नहीं छूटा, कुछ पॉइंट छूटे भी तो क्वेश्चन आंसर सेशन में हमें उनका लाभ मिला. तो इतना अच्छा सेशन देने के लिए नीता मैम को बहुत बहुत धन्यवाद. सभी भागीदार जो पार्टिसिपेंट्स हैं जिन्होंने ज्वाइन किया, उन सबका थैंक्स. और हमारी सीईओ है सारंगा मैम, सारंगा पवार मैम, उनका बहुत बहुत धन्यवाद. उन्होंने सेशन हमारे लिए अरेंज किया. थैंक यू एवरीवन. थैंक यू मैम.
Thank you again.
Over to Indra ma'am.
Yeah, thank you again, everyone. And we'll wind up this webinar. Thank you, Dr. Nita ma'am, for such a wonderful webinar. Thank you. Good night.
Ma'am, sorry for the interruption. Can I ask a question, ma'am? Sorry to ask after this vote of thanks. I'm a sister of a hemophilic patient, a factor 8 male patient. And recently my mom was like severe anemic because of heavy menstrual bleeds, ma'am. So can we use any medications to reduce that severe menstrual bleed of my mom, ma'am?
So your mother is a carrier, right?
Yes, ma'am. My mother is a carrier and my brother is factor 8 hemophilic one.
So get a factor 8 level done for her, and then based on the level, let's see how much it is, and then we decide what to do. If it is very low, then you treat her like any other bleeding disorder. If it is not very low, maybe you just give Tranexa during the menstrual cycles. That should be okay. But first to get a proper evaluation done. Get her factor 8 level, get her to be seen by a hematologist, And then once
Yes, ma'am.
level comes, let us categorize her, whether it is less than 40, and in that less than 40, is it less than 1, 1 to 5, 5 to 40, or is it more than 40? And then accordingly, we will discuss, we can discuss what are options we can give for her, but get her evaluated.
Okay, ma'am. Thank you.
Thank you, everyone. Good night.
Thank you. Good night.